Now that you have had a taste of the real surgery from PJ's talk, let's go back once again to something more basic, which is imaging. And the aim of my presentation is actually very simple. First of all, it is being presented from a surgeon's point of view, which is actually important because after all, we are the end user of this imaging technique. And I will try to make it as simple as possible. And what I'm trying to do is rather to illustrate concepts. Why are we doing this set of imagings and how are we going to use it, rather than showing you something which is very rare. And if you look at the available technique nowadays, we can have plain radiography to MRI perhaps. But among this, I think the CT is the one which is preferred by most of the FESS surgeons for a number of reasons. And for the traditional technique with the plain X-rays, actually there's no application with FESS nowadays because it doesn't actually show the delicate bony structure very well. And there's a lot of overlap. Because in the skull itself, in the sinuses itself, whether you look at it one way or the other, there's a lot of overlap, unless we can see the structures in tissue planes. And perhaps this is one step forward, that we can see tissue in planes when we are doing this traditional tomography. But the problem with this is that there's a lot of radiation received by the patient to the lens and to the thyroid glands and so on. And that's why unless CT is actually not available, traditional tomography, again, is not very applicable in FESS. How about MRI? MRI, actually, we can get a very good detail of the anatomy of the area. But one of the drawbacks is that the bony structure is actually not shown positively in the MRI, and this is actually shown up as a tissue void when we have bony structure. But in FESS surgery, I think the most important landmark that we always refer to are the bony landmarks, and they are the constant landmarks that we need to refer from time to time. And so once again, I think at this point, MRI is actually not preferred by most of the FESS surgeons for the reason I just mentioned. And CT scan perhaps is the most commonly used technique of imaging when we are contemplating FESS surgery. First of all, you can see all the structures very well, delicate bone structure, and we can see the structures in a plane perspective. And we are there also a good reasonable tissue density when we manipulate the window of the CT scan settings. And that's why it is preferred by most of the FESS surgeons nowadays. And what I'm going to illustrate now is a few principles of how and when and why are we using this imaging for FESS. If we look back from this point back in time, I think FESS surgery can be so successful and being applied to the nose, to the sinus and beyond. One of the reasons for that is because we do have very accurate imaging techniques. Without this, we will not go any further. But when we are applying this principle to our FESS surgery, we have to pay attention to a number of important points that we have to bear in mind all the time. First of all, timing of the investigation, the accuracy of CT scan, and the setting of the CT scan machine, and how are we going to interpret the findings. And after all, there's also a lot of practical issues, like our relation. We should have a very good radiologist friend so that we can understand each other. Otherwise, the way they do the scan may not be the way you want it done. So let's look at these parameters one after the other. Timing. Timing is very important. First of all, because a lot of this sinus disease is potentially reversible. If we do CT scan, let's say for anybody, during the time when they have a flu, I think you can pick up very gross abnormality. But a lot of those are actually reversible. But unfortunately, the CT scan cannot tell one way or the other whether this pathology that we have picked up from the CT scan is going to be reversible with treatment or not. And that's why when we are ordering CT or any sort of imaging for FESS, we have to have the patient treated conservatively, adequately. Because otherwise, a lot of this potentially reversible element will be picked up by the CT scan, and by the time you operate on the patient, it may not be there. And the second thing is concerning timing is when you have ordered a set of CT, if it is a few months before your surgery, by the time you operate on the patient, the condition may have changed. It can get worse and it can be better. And that's why the closer to the time of surgery, the better will the pathology picked up by the CT be reflected in the actual situation. And accuracy. This is actually a trade-off. I think it is very easy to understand that if you increase the distance, that means that you are doing less cuts for a particular area. You are going to see it less accurately. The finer the cuts, the more details you are going to get. And the more overlap between the cuts, you are going to get more details from the CTs. In a standard treatment in a hospital, we have done it in 3 to 5 millimeters with certain degree of overlap. And the area that we overlap is where the key sinuses are draining, between the osteomeatal complex area or the frontal recess area. And that's the area we need very fine details. And if you are also doing, say, image guide surgery, again, you also need very fine cuts, because in order to reconstruct the tissue planes in all the 3 dimensions, you actually need to have fine details. But as I said, it is a trade-off, because the more cuts you do for your patients, the higher the dose of irradiation the patient will receive. Like in the traditional setting, with an average of about 18 cuts or to 25 cuts, the amount of radiation to the lens is between 5 rads to about 6 rads. But if you are doing, say, image guide surgery, like previously we have been using the insert track, it is essentially axial image. And that's why the amount of irradiation to the lens can be a lot more. But because we are doing axial image, the amount of radiation received by the thyroid gland is actually very little. And the brain nap is something in between. They do both coronals and axial cuttings, and that's why the dose of irradiation can be variable. But one thing is, the more cuts you have for the patient, the more irradiation the patient will have. And one of the rough calculations that we can refer to is, for every cut we have for the patient, approximately 0.6 rads of irradiation is received by the patient, referred to the lens, that is. And secondly, the setting. We must have the appropriate window setting for the CT scan when it is being ordered. And that's why you need to be liaising with your radiologist, so that they would know what setting you want. And in the for FESS surgery, let's say, we are actually very interested, or more interested in the bony anatomy, not so interested in the bone tissue density of the soft tissue. And that's why we set the window to be very wide, so that we can get a detail of the bony structure, even very fine bony structures. But on the other hand, we do not need a lot of contrast within the soft tissue densities, unless we are looking for some other pathology, like a tumor. And normally we would do coronal cuts, but actually if you have good radiologists who can sometimes do a field reconstruction in the axial plane for you, so that you can have a more detailed anatomy in a perspective, in a front to back perspective. And because that is the way we are going to approach the patient during surgery. And if necessary, we should always ask the radiologist to do some reconstruction in the sagittal planes. Interpretation of the CT. I think in this area, as clinicians like ourselves, we are actually in a better position to interpret the radiograph, the CT scans, than our radiologist friends. And that's why sometimes if we do have these X-ray meetings, so that we can have information communication, good communication between us and the radiologist, this will enhance the way it is interpreted. Because after all, we have the access to the history and the physical finding, and then we look at the CT, and one step further, we actually operate on the patient, and we know what is happening. And therefore, it is actually much better for us to look at all the CT. Don't just rely on the report from the radiologist, because they have to make it very safe. They sometimes list a list of differential diagnosis, but you can know for sure what it is. Like in this case, if a radiologist probably will report this one as probably a mass in the nose with secondary sinusitis. With a differential diagnosis, this can be inverted papilloma. Because it is unilateral, it can be a tumor. But if you have looked at the patient, you know for sure it is a polyp. And that is the advantage we have as clinicians, that we actually, apart from the history we get from the patient, we actually being able to examine the patient and interpret the CT scans with that additional information. And we also get the history, as I said. If this patient with previous surgery, this is a patient who has previous FESS surgery, and as PJ has mentioned, orbital penetration is quite common. And it is one of those patients with previous surgery, orbital penetration, and then with residual sinusitis, probably due to inadequate surgery after you have penetrated the orbit. And the way to interpret is very easy. If it is your patient, of course you know, but if you also got a history, the patient may be operated by somebody else, perhaps this is something you should bear in mind. There may be orbital penetration from before. It is not just important from the surgical aspect, but also important from the medical legal aspect. And when we look at this CT scan, we've tried to look at it in a systemic manner, and that's why you need to develop your own system. But two things we need to get from the CT scan. First of all is the pattern of the disease. That means the extent of the disease involved. And how are they related to each other? And there's a few common patterns that we can refer to. Sometimes we may have an isolated sinusitis, like the one I just showed you previously. Due to inadequate surgery after orbital penetration, the maxillary sinus, the infundibulum, is actually all blocked up. One, and the other is the different sinuses that drain and share one common pathway, usually may be affected together. And that's why we have disease of the sinuses which will be related to one another. And if we got this information, we know the extent of surgery that we need at the time of operation. And sometimes for a patient with diffuse sinonasal polyposis sinusitis, perhaps there's an underlying pathology, like a patient with immunodeficiency or patient with cystic fibrosis and so on, or immotile ciliary syndrome. And this group of patients, we may tackle it slightly differently. And sometimes you may encounter some odd patterns of disease. In this case, you should be careful, particularly for those who have previous surgery, or else it can be something rather unusual, like a neoplasia. Just give you some example. This is a patient with infundibular obstruction. You can see only the maxillary sinus is being affected because the site of obstruction is in the maxillary infundibulum. And in this case, diffuse sinonasal polyposis, you can see that the nasal fossa can be relatively clean, but all the rest of the sinuses is grossly being affected. And this one, osteomeatal complex disease, an obstruction here in osteomeatal, perhaps the narrowest drainage common pathway, and the maxillary sinus is secondary involved with a fluid level that you can see. And this is an MRI, of course, but what I try to illustrate is, if you have a patient like this one, the upper part of the sinus is being affected by disease while the lower part remains relatively normal. It is not a common pattern that sinusitis will occur in any sinuses. And if this is the case, you should be careful of something maybe more odd, like a neoplasia. And in fact, this is actually a patient with a carcinoma. And then we should look at the scan once again and trying to looking for anatomic variation. That is, after we got the overall pattern of disease involved by first going through, and then we should go back and look at it again in more detail to look at some important landmarks and for anatomic variation, which can be very useful during surgery. Like in these patients, you can see going from front to back. In the very first cut, you can see that the patient got nasal polyps. He has previous surgery. That's why the turbinate is actually gone, the inferior turbinate. And as you go further back, you can see that the polyps become more obvious, nasolacrimal duct, and all the sinus at this point is being totally involved. As you go further back, maxillary sinus completely affected, anterior ethmoid completely affected. You can see here that the olfactory fossa in this patient tend to be lower. As you go further, now you can see the frontal recess start to open up, but again completely opacify. And here you can see a dimple starting to develop. As you go further, this is the anterior ethmoidal artery. You can see this dimple, and you can imagine that the anterior ethmoidal artery is actually overhanging in this situation. And in fact, a corresponding point can be seen on the other side. The posterior ethmoid, as it starts to show up here, appear to become relatively normal. And you can see that canal for the anterior ethmoidal artery more clearly now. Posterior ethmoid very clean. But once again, all the rest of the sinuses is being affected.
posterior ethmoid clean. And the sphenoid sinus is actually also totally involved. And if you have a sagittal reconstruction, you can see the frontal, the ethmoid, and maxillary sinus all block up, except for the posterior ethmoid. But once again, the sphenoid sinus completely blocked up by disease. And so you would know for sure what the extent of the disease, some anatomic variation of this patient. And some practical point actually is also very important. And you should always have good communication with your radiologist. If they vary their techniques, if you have many radiologists in the hospital that do scans for you, and you don't know what particular cuts they are going to use, sometimes it may be less useful than you want because it is not being done the way you want. And you should actually work out a routine that you would stick to. Even though there may be many radiologists working in the hospital, if you can have an agreement with the radiologist in charge, and then all the radiologists can use the same setting, and that will make it easier for you to interpret your CT scans. And if you are doing CT for a particular or special indication, you should always warn the radiologist, because then they may need to modify their techniques slightly. Like in this case, an angiofibroma, again it is an MR. Normally when we do CT for FESS, we don't need contrast. But if you are, say, suspecting a patient having tumor, angiofibroma, then you need to have contrast. And if you are looking for CSF leak, then you probably have very fine cuts through certain areas that you want the radiologist to go through with very fine cuts. Otherwise, you can miss it. And this is some of the important points that I just like to reiterate. And imaging is very important for FESS, that is for sure, and that you have to use the correct technique. And the principle of application from when you order a CT scan, when you look at the CT scan, when you decide to operate on the patient. But one thing that is very important is we should not just treat the CT scan, we should treat our patients. Because if sometimes the CT and the patient's symptom may not correlate, and then you may not necessarily go and operate on the patient. And finally, that's actually an ideal that we should all have when we look at the CT scan of the patient, which is that when we look at the CT scan in a systemic manner, we should be able to reconstruct what is going on inside the real patient, as illustrated by this one, which is an animation from CT scan and endoscopic finding on the same cadaver. But certainly this should be the ideal behind our minds when we look at the CT scan again and again. And in fact, we can do it because, as I said earlier on, we are the one who order for the CT. We are the one who use the CT. We have the benefit of history, clinical findings, and also the benefit of surgery. We can verify whether the CT is actually correct or not. This is quite an illustrative video clips that I get actually commercially available. It's not from us actually. But I just try to illustrate the ideals that we all should have, is to reconstruct the real situation in our mind by looking at the CTs. And with that, I would end my presentation. I know time is running a little bit short.